Radiation-induced brachial plexopathy, or RIBP, is a serious complication that can arise after radiation therapy for cancers near the lung, chest wall, head, neck, or breast. This condition involves damage to the brachial plexus, a network of nerves responsible for movement and sensation in the arm and hand. RIBP can develop either soon after treatment or many years later, making it a long-term concern for cancer survivors. The symptoms can range from mild tingling to severe weakness or even paralysis, significantly affecting quality of life. Understanding RIBP is crucial for patients and healthcare providers alike, as early recognition can help guide management and support. Risk of developing RIBP depends largely on the total dose of radiation received during cancer treatment. Historically, higher doses led to more cases, but advances in radiation techniques have reduced this risk. For example, breast cancer patients once faced incidences as high as 15%, but now rates are closer to 1%. Other risk factors include previous chemotherapy, additional surgeries, and certain patient characteristics like age, diabetes, or autoimmune diseases. Understanding these risk factors helps doctors tailor treatments and monitor those at higher risk more closely. RIBP can present in two main forms: early onset and late onset. Early onset RIBP usually appears within the first year after radiation therapy, often causing tingling, pain, and weakness in the arm. Fortunately, about 80% of these cases resolve on their own. Late onset RIBP, however, may develop several years after treatment and tends to be more severe and permanent. Symptoms can progress from numbness and pain to significant muscle weakness and even paralysis. Recognizing the timing and progression of symptoms is essential for proper diagnosis and management. Underlying cause of RIBP is damage to nerve tissue from radiation. In the early stages, radiation can cause inflammation, swelling, and temporary changes in nerve function. Over time, chronic inflammation leads to fibrosis, a thickening and scarring of tissue. This fibrosis can constrict nerves, block signals, and reduce blood flow, resulting in lasting nerve dysfunction. Key molecules like transforming growth factor beta and connective tissue growth factor drive this fibrotic process, making it difficult to reverse once established. Understanding these mechanisms is vital for developing future treatments. Diagnosing RIBP can be challenging because its symptoms often mimic other nerve problems such as tumor recurrence or carpal tunnel syndrome. Patients may first notice tingling or weakness in the hand, which can spread to the arm. Over time, muscle atrophy, loss of reflexes, and even complete paralysis can develop. Doctors rely on a combination of patient history, physical exams, and specialized tests like MRI and nerve conduction studies to confirm the diagnosis and rule out other causes. Early and accurate diagnosis is key to managing symptoms and improving outcomes. Imaging studies, especially MRI, play a crucial role in evaluating RIBP. MRI can reveal thickened nerves and help distinguish RIBP from tumor recurrence. Electrodiagnostic studies such as EMG and nerve conduction tests provide further insight by measuring how well nerves transmit signals. These tests can identify specific patterns of nerve damage unique to RIBP, such as slowed conduction and myochemic discharges. Together, imaging and electrodiagnostics help doctors confirm the diagnosis and plan appropriate treatment strategies. Currently, the main goal in treating RIBP is to manage symptoms, as there are no proven ways to reverse or halt the disease. Physical and occupational therapy help maintain joint movement and muscle strength, while medications like antidepressants, antiepileptics, and pain relievers target nerve pain. Hyperbaric oxygen therapy has been explored, but results are mixed and it does not address the underlying fibrosis. Researchers are investigating antifibrotic drugs, but so far no medication has shown clear benefit for RIBP. Supportive care remains the cornerstone of management. For patients with severe unmanageable pain or significant functional loss, surgery may be considered. The most common procedure is neurolysis, which involves removing scar tissue around the nerves and sometimes adding healthy tissue to reduce further fibrosis. However, surgical outcomes are unpredictable. About half of patients experience pain relief, but fewer regain strength or sensation. Some advanced procedures like nerve transfers aim to restore specific functions but require careful patient selection. Surgery is generally reserved for those who do not respond to less invasive treatments. Despite decades of research, RIBP remains a challenging condition with limited treatment options. The main obstacle is the irreversible nature of radiation-induced fibrosis, which resists current therapies. Future advances depend on developing drugs or interventions that can prevent or reduce fibrosis during planned radiation therapy. Promising areas include antifibrotic medications and stem cell therapies, but more research and reliable animal models are needed. Ultimately, prevention is key. By targeting the root cause, we can hope to protect nerve function and improve quality of life for cancer survivors.